Good evening, all students, participants. Today, we will be discussing some important concepts for interpreting electrophysiology studies. And this will be the last class as far as introduction is concerned, because next class onwards, we'll be dealing with specific diseases and electrophysiology findings in those diseases. So, as a prelude to that, we should revise some of the concepts which we have been doing last 2-3 classes. So there are two terms which we come across in electrophysiology studies. Those are called orthodromic and antidromic nerve conduction studies, which are which are very important to understand, because some of the studies which we do are orthodromic and some are antidromic, and this will come to know in next slide. If you look at the physiological nerve conduction, the nerve conduction studies typically involve mixed nerves, such as both they have sensory and motor nerve fibers. Compound muscle action potentials are recorded with in motor nerve conduction studies, and these propagate from the anterior horn cell distally towards the neuromuscular junction and muscle. The sensory nerve action potentials that are recorded in the sensory nerve conduction studies, they propagate from the sensory nerve endings proximally towards the dorsal root ganglion. So orthodromic is different for motor nerve conduction studies as well as sensory nerve conduction studies. So you keep that in mind for the next coming 2 slides. You require that. Propagation of an induced action potential during nerve conduction studies, what we do is we stimulate the nerve, and that action potential travels in both directions, proximally and distally. So depending on the recording electrodes which measure this action potential, we can adjust our conduction studies. In an orthodromic study, the recording electrodes measure the action potential that is traveling in the physiological direction. Suppose you want to record the CMAP of median nerve, then you attach the recording electrodes onto the abductor pollicis brevis belly, and proximally you stimulate the median nerve. So that's orthodromic. In an antidromic study, the recording electrodes measure the action potential that is traveling opposite the physiological direction. It's one thing is not only to know how to do the nerve conduction studies and how to interpret the waveforms that you're going to see, and what will be the anomalies in the nerves that will give rise to some type of confusion, like Martin Gruber anastomosis, which we're going to study. So these are important issues which we'll deal in this class. During it's a volume conduction during nerve conduction studies are motor conductions are orthodromic, as I said, and sensory nerve conductions can be both orthodromic and antidromic. So you can record either way, but for motor it is always orthodromic. When you conduction velocities and latencies are equal in both the directions, so there is no issue in this. But what one prefers while recording the sensory nerve action potential, these antidromic snaps, and they are larger than the orthodromic snap amplitudes because of one specific reason. The superficial cores of the sensory nerves are distally, so you can easily tap them, and so the recording electrode is very close to the signal that is generated, so you get good amplitudes if you do antidromic. What is antidromic for sensory nerve is your recording electrodes are situated proximally and you are stimulating distally, that is the orthodromic. If you stimulate proximally and recording electrodes are distally, that is antidromic, because the sensory nerves action potentials are from the receptors towards the dorsal root ganglion. So that's the difference. Amplitudes of orthodromic snaps are smaller as the distal branches of the nerves are thinner and are less excitable. So we prefer to do antidromic snap amplitudes and in the studies. The motor nerve conduction studies, as I said, they measure compound muscle action potential in the physiological direction such that the stimulation site is proximal and the recording electrode is placed distally over the muscle belly, in this case, abductor pollicis, previous which we showed in the last class also. Orthotomic median sensory nerve conduction study, electrodes and stimulator placement. If you're looking at the stimulator, this is the orthotomic sensory nerve conduction study. Median nerve you are stimulating in the mid palm, and the recording electrode is placed proximally. This is a normal direction of the sensory input to the spinal cord. That's why it is called orthotomic median sensory nerve conduction study. Sensory nerve studies can be performed, as I said, both antidromically as well as orthodromically. During the antidromic recordings, the nerve is stimulated proximally and the recording electrode is placed distally. What I showed is the opposite. That is orthodromic recording. The sensory nerve is stimulated distally and the recording electrode is placed proximally. If you reverse this, that becomes antidromic. Well, however, the both orthodromic and antidromic sensory nerve conditions are used to obtain combined sensory index, which I mentioned in the last class also. This utilizes a comparison of the median and ulnar nerve latencies, in which the antidromic study is recorded at the fourth digit and stimulated over each nerve proximally, and the orthodromic study is recorded over the proximal respective nerve and stimulated in the mid palm. So this will again study when we study carpal tunnel syndrome. So these are the two issues which you should remember. We'll come back to it. So median sensory nerve conduction antidromic, as you see, the recording ring electrodes are placed in the index finger and the stimulation is on the nerve. This is opposite to the normally the sensory input goes to the spinal cord like this. But now you are doing it in opposite direction. And antidromic sensory nerve conduction studies will give larger amplitudes. The higher amplitudes observed in these studies are considered an advantage. However, some small disadvantage is there. That is, the proximal stimulation is performed on a mixed nerve. So both CMAP and SNAP are obtained. So the CMAP recording will make confuse the SNAP. So we have to carefully differentiate between CMAP and SNAP when you are doing antidromic conduction. If you do orthodromic sensory nerve conduction study, the motor nerves are not stimulated at all because they are not there. And so CMAP is not a problem. However, anatomical variations such as digital limb size can contribute to the amplitude differences in snaps. So the amplitude of the median snap in both orthodromic and antidromic studies has been shown to be inversely proportional to the wrist thickness. The amplitudes of both median ulnar antidromic NCS is inversely proportional to the finger circumference. So you see, that's why for sensory nerve conduction studies, its elicitation of a good snap is important. It's not the amplitude of the snap. I think you should be able to elicit a good snap. So every resident should go and do snaps and CMAPs of median, ulnar, radial, and posterior tibial and common peroneal nerves, the lower limbs. And you should do and see for yourself how you elicit the compound muscle action potentials, how you elicit the F waves, how you elicit the sensory nerve action potentials, how you calculate the nerve conduction velocity. You should do yourself, and that's a important thing is you should practice. Don't rely on the technicians only. You have to teach the technicians and correct them. They may not be doing the right things. So how do you interpret the NCS and EMG studies, and what is the utility where they come into vogue, and what are we may be recapitulating what we learned earlier, and it's always better to relearn some of the things. Nerve conduction and needle EMG interpretation require knowledge of normal values and understanding of the significance of variations from normal. Usually the normal values are established for your own lab, and whenever the machine is bought newly, you please go on doing 15, 20 normal studies, and take an average of all the latencies, all the conduction velocities, all the CMAP amplitudes, and record them. That is your normative data. It's slightly akin to whatever is published in the book, but your machine has to be validated. That's an important point you should keep in mind. The abnormalities can help in diagnosing a focal neuropathy, and we can distinguish a demyelinating neuropathy from an axonal neuropathy. We can detect a myopathic process with these studies. And how we do demyelinating neuropathy, the characteristic features are prolongation of the distal latency, prolongation of the conduction velocities, prolongation of the F latencies, and axonal neuropathy is characterized by a loss of amplitude in the CMAP. And so that's how some of the interpretations which we come across. So let's look at the neuroconduction studies. And what the question which asks is, where is the lesion? Neuroconductions can be used to determine whether the lesion is distal, proximal, or segmental. Most importantly, distal latency. Is there slowing along the distal segment? Distal, or what you call as onset latency, can be used to determine whether the lesion is distal. The latency measure is greater than the normative value, it is considered prolonged. This is consistent with the slowing along the distal segment of the nerve. There are two types of distal latencies that can be calculated. One is the peak latency, one is the onset latency. The time interval from the stimulation to the initial deflection of the waveform in motor nerve conduction studies typically uses onset latency for assessment. It's a measure of the fastest conducting motor fibers. This is the onset latency. You should remember that motor nerve conduction is not a pure test of time required for the motor nerve to travel, because it also accounts for time required for the electrical signal to travel from the stimulus site through the nerve segment, the time required to cross the neuromuscular junction, and the time required for the muscle cell membranes to depolarize. So this is a much more robust distal latency than the snap latency. Snap latency hasn't got all these things. So whenever you are talking of the neuroconduction studies, you should keep in mind that the time that is taken for all these things, that from the stimulation site to the neuromuscular junction and to the muscle. Peak latency is the time interval from the stimulation to the peak of the waveform, which you can see the peak latency. Sensory neuroconduction studies typically use peak latency for assessment because the responses there are very smaller. And if you have done this in your lab, you will understand. It can be challenging to define a clear takeoff point for onset latency as far as snaps are concerned. Here, there is no involvement of neuromuscular junction or muscle depolarization. So thus latency is more of a pure test of time that is required for the sensory nerve action potential to travel. So actually this is less reliable than motor nerve conduction studies. So as far as our teaching goes, that if you are able to elicit a good snap, that is helpful, because snap elicitation is very important. For all the postganglionic lesions, the snaps will be absent, and for all the preganglionic lesions, the snaps will be present, which we'll discuss in due course of time. The second important aspect is the conduction velocity. It can be used to determine whether the lesion is distal, proximal, or segmental. The velocity is a representation of the speed of the fastest conducting fibers. You see, the sensory fibers are not fast conducting fibers. The motor fibers, because of the myelin, the Ranvier nodes, the saltatory conduction, they are the fast conducting fibers. For motor nerve conduction studies, the two stimulation sites for the same muscle must be used in order to account for the neuromuscular junction and the muscle depolarization time. The change in the distance divided by the change in time can then be calculated. So usually all the machines will, if you feed the distance, and it will automatically come. For sensory nerve conduction studies, this is more directly calculated by dividing the distance traveled by the onset latency. Peak latency cannot be used to conduct conduction velocity. Normal values for conduction velocity is upper limb greater than 50, lower limb greater than 40. Here the abnormality is if it is less than 50 in the upper limbs and less than 40 in the lower limbs. The value of the velocity is less than the normal value. It is considered abnormal and represents an abnormality across the segment being tested. Let's look at the example of ulnar neuropathy. The carpal tunnel syndrome, compression of the ulnar nerve in the cubital tunnel, which can be determined by comparing the conduction velocity of the ulnar nerve across the elbow. So, sorry, I'm not the carpal tunnel syndrome, it's at the elbow. When you suspect that there is an entrapment neuropathy at the elbow, what we do, we stimulate the nerve above elbow and below elbow. So if there is a compression of the ulnar nerve in the cubital tunnel, this can be determined by comparing the conduction velocity of the nerve across the elbow to the distal conduction velocity in the forearm and the proximal conduction velocity in the upper arm. So there is a slowing of more than 12 meters per second at the elbow. In comparison with the wrist or upper arm, it is consistent with segmental compression. So entrapment neuropathy is whenever you suspect the conduction velocity will help us in determining that. So we have dealt with distal latency, or dealt with the conduction velocity, and we're going to do with amplitude. The amplitude is axon loss or conduction block that is present. Whenever amplitude is diminished, this is the amplitude which you are seeing from here to here. But if it is diminished, it could be because of axon loss, or it could be because of conduction block. It can be used to determine whether the axon loss, conduction block, or both are present along a nerve segment. How do you define amplitude? Defined as the maximum height of the response as measured from the baseline, the peak, or peak to trough. These are the two things that are used. Normal amplitude values are vary from lab to lab and are equal to or greater than the values listed on the table of the normal values. What affect this amplitude is axon loss, conduction block, or both. They cause amplitude less than the normal values. The amplitude will be abnormal within the stimulation, both proximal and distal to the site of injury, because of Wallerian degeneration and the death of the entire axon distal to the site of the injury. But not conduction block. Conduction block, the amplitude will be decreased if stimulation occurs proximal to the injury and normal if stimulation occurs distal to the injury. This is secondary to focal demyelination, which is severe enough to block some or all conductions that pass the point. A proximal amplitude decrease of 20% or more than the distal amplitude is consistent with conduction block in most nerves. Axon loss also can coexist with conduction block. The amplitude with the stimulation both proximal and distal to the injury will be decreased due to axon loss. The amplitude with the proximal stimulation will be decreased to greater degree than by at least 20 degrees due to the concomitant conduction block. So conduction block will diminish the amplitude proximally. So it's important point to note. And whenever you look at the neuro conduction studies and start interpreting them, you should know whether conduction block is there or not. What type of lesion it is? So we'll try and usually basically we give two types of diagnosis: a neuropathic lesion or a myopathic lesion. We'll give the examples for both. Neuroconductions, they help determine whether lesion is neuropathic or myopathic. Neuropathic lesions can be located more proximally, such as the radiculopathy, and more distally, such as plexopathy. What happens in radiculopathy? The sensory neuroconduction is normal because the injury is proximal to the dorsal root ganglion, because the dorsal root ganglion is proximal to the injury. In postganglionic, there is post dorsal root ganglion lesions. Both sensory and motor axons are involved in Wallerian degeneration and hence show abnormalities. The myopathic lesions, the sensory and motor neuroconductions are typically normal. The EMG is needed for diagnosis. That's why when you do EMG, you will try and look at the insertional activity, whether it's prolonged, or you try and look at motor unit action potentials, their amplitudes, their phases, their polyphasia, what is the interference pattern. All these things will tell us the myopathic pattern, and EMGs that's why needed. However, in distal myopathies or severe myopathies in which both proximal and distal muscles are affected, the motor nerve conduction may have low amplitudes. So let's look at some examples of neuropathies that can be defined as primarily motor or primarily sensory. Friedreich's ataxia is typical prototype primary sensory neuropathy. The nerve conduction studies findings are typically demonstrate decreased or absent sensory potentials and normal motor potentials. On the other hand, multifocal motor neuropathy with conduction block is primarily a motor abnormality. Here, the conduction block is very well demonstrated on motor nerve conduction studies, and the snaps are normal. After how long the changes will start appearing? Now, when do you start interpreting the how long the injury is, long has the lesion been present? You can know. So what happens is after nerve injury, motor axons may remain excitable for up to 7 days, and sensory axons may remain excitable for up to 11 days. So with even severe proximal nerve injury, stimulation distal to the injury may result in a normal or only mildly abnormal values during this time period. So stimulation proximal to the site of injury will result in absent responses in both motor and sensory studies, making it very difficult to distinguish axonal loss versus conduction block. So it is thus recommended to wait 10 to 14 days after the injury before performing a nerve conduction studies, as the difference in pathology becomes clearer after this time. That's easy clear. So people often refer for electrophysiology testing after the injury, but you see that at least 2 weeks gap is there after the injury and when you start doing the tests. That's the reason because they remain excitable for a longer time. So what are the other factors that affect nerve conduction studies, and what are the factors that affect the interpretation of the results? If there's a decrease in limb temperature, this could prolong the latency, increase the amplitude, and decrease the conduction velocity. All features are suggesting that it's a demyelinating neuropathy. It's people, especially who are living in cold climates and northern India and all, should keep in mind what's the limb temperature in winters. There may be measurement error of distance that could limit the calculated conduction velocity. There may be anatomic anomalies may lead to unexpected sensory and motor NCS findings. These anatomic anomalies we are going to discuss in the end in this class. If an individual has edema or subcutaneous tissues that have analyzed, that could impact the level of the stimulation, which leads to falsely decreased amplitudes. You should have a clinical sense of what you are measuring and whether the stimulus is potent enough to generate an action potential or not. So that's very important for you to understand. So now that finishes the part of nerve conduction studies, and let's go to the EMG interpretation. As we know that EMG, the phases, amplitudes, and there are 4 components of EMG studies which you should keep in mind. Insertional activity, as you put the needle inside the muscle, and there will be, if you don't move it for some time, there will be some activity for 1 or 2 seconds and that disappears. That is insertional activity. Then there will be spontaneous activity along with this, which will have, if may come across positive shock waves, fibrillation potentials, and also fasciculation potentials. You can understand these are the spontaneous activity that can suggest to us whether it is a degeneration pattern, a denervation pattern, or renervation patterns. Then you look at the motor unit morphology. It's a motor unit action potential. Then you look at the motor unit recruitment and the pattern of muscle abnormalities, which can be studied later on. The electrical activity associated with the movement of the needle to the muscle and for several seconds after stopping the needle movement. So last time I told you that you do 4-quadrant exercise in this. After entering the needle, after entering the muscle, you keep the needle there for some time and look for the sensational activity. And when you stop movement, there will be some seconds the electric activity will persist. Then just withdraw and put it in another direction. Wait for some time. A normal electrical signal with the movement of the needle in muscle with no prolonged activity of stopping the needle movement is acceptable, except in neuromuscular and end plate region, where last time I showed you that there were end plate spikes, where miniature end plate potentials and end plate spikes may be seen after the needle movement is stopped. So accept that, but this is prolonged in cases of polymyositis. Seen in normal muscle, reinnervation, denervation, myopathy, neuromuscular junction abnormalities, the insertional activity can be seen normally. Insertional activity can be increased or decreased, and these are the things which I was trying to tell you. The continued electrical activity of stopping the needle movement means you got positive waves, fibrillation potentials, they indicate denervation. Complex repetitive discharges may be seen in chronic denervation. The myotonia associated with myotonia congenita, myotonia dystrophy, and neuropathic disorders will have a very peculiar sound, diabomber sound, that you can hear when myotonia. When we do myotonic congenita, will atrophica will show you that. The lower amplitude, muted sound of electrical activity with needle movement to the muscle is seen in fibrous replacement of muscle tissues in old innervation, chronic myopathy, rhabdomyolysis, and also hypokalemia. There will be no sound. And if you want to check whether hypokalemia is there or not, you do the needle EMG, there will be no sound, no insertional activity. Look at now the phases and duration of MUAP, motor unit morphology, the number of phases, number of duration and amplitude. I'm just refreshing you from last time. The number of baseline crossings plus 1 is the phases. So 4 or less phases is a normal finding seen in normal muscles under recent denervation less than 6 weeks, neuromuscular junction abnormalities. However, 5 or more phases are polyphasic and abnormal, seen in nerve sprouting, reinnervation, and myopathy. Well, this is a non-specific finding. Look at duration. If it is 5 to 15 milliseconds, it's generally normal, but it varies by muscle. Normal in normal muscle, early denervation, and old reinnervation. It is increased in chronic denervation and associated with polyphasic potentials, also decreased in myopathy. Myopathic duration is decreased, amplitude is decreased, and there will be total complete interference pattern. The amplitude, as I said, motor unit morphology, the number of phases, duration, and amplitude you have to study in this one. The phases, how many phases are there? The normal is seen 1, 2, 3, and the duration. Amplitude 200 to 2000 microvolts or 2 millivolts is generally normal, but varies by muscle. And it's normal in most of the conditions, normal muscles, early and chronic denervation with reinnervation. It's increased in old reinnervation and decreased in myopathy, as I said earlier. Now, the motor unit recruitment and the repeated firing of motor units during muscle activation. You ask the individual to slightly contract and contract somewhat fast. When you are recruiting more motor units, the repeated firing of motor units happens during this muscle activation. Rapid firing frequency of fewer motor units is seen with conduction block or denervation, that is incomplete or decreased recruitment. Early firing of many motor units with minimal force is generated, seen with myopathy, may be normal in mild denervation and mild myopathy. So EMG changes can be also studied over time after axonal nerve injury. We can see immediately 1 to 2, 3 weeks, 3 to 6 weeks, also 6 weeks to 1 year, 1 year or more. What are the changes are going to happen? So immediately there is a decreased recruitment of normal appearing motor units after the injury, axonal nerve injury. There is a nerve injury. What happens is that there is a decreased recruitment of normal appearing motor units. Normal insertional activity, it takes 1 to 6 weeks after severe nerve injury for Valerian degeneration and muscle membrane instability to occur. So there will not be any fibrillations or positive shock waves immediately. 1 to 3 weeks, there will decrease recruitment as previously I have described. The denervation changes are seen in paraspinal muscles. Because the paraspinal muscles are the most proximal muscles, they're the first to show signs of denervation. Paraspinal muscles may have positive sharp waves and fibrillations during starting 1 to 2 weeks after the acute injury. Decreased recruitment and paraspinal muscle denervation is seen 3 to 6 weeks. In addition, there will be active denervation of the limb muscles. At 3 to 6 weeks, Wallerian degeneration has occurred. Positive sharp waves and fibrillations appear in the distal muscles also. The abnormalities will be seen the last in the foot and hand muscles. The proximal muscles show more abnormalities. 6 weeks to 1 year after the injury, the decreased recruitment, positive shock waves, and fibrillations disappear as the muscle fibers are re-innervated. However, motor units with long duration and polyphagia. Several months after the injury, axonal sprouting occurs. This means that the remaining axons will now be re-innervating muscle fibers that were earlier denervated. Because the newly formed nerve sprouts innervating these muscle fibers conduct more slowly, they will not fire synchronously with the rest of the muscle fibers that are innervated by the motor units. So therefore, the motor unit morphology will have longer duration with increased phases. If more than 1 or more years, decreased recruitment, that is incomplete interference also. Polyphasic motor units become triphasic because of motor units now have mature myelin on the sprouts that re-innervated, denervated muscle fibers, and the fibers fire synchronously. Motor units have large amplitudes because of the synchronized firing of the larger number of muscle fibers, what we call giant action potentials. So some of the patterns and the disease states, let us see. In focal neuropathy, what happens? How do you test if you are suspecting a focal neuropathy? You should select 2 or more abnormal muscles innervated by the same peripheral nerve but by different nerve roots. So you're trying to diagnose a peripheral pattern in a focal neuropathy. What you do is, in median mononeuropathy, if you are suspecting, so flexor carpi radialis muscle, which is innervated by the median nerve, has got a root value of C6 and C7, whereas abductor pollicis brevis has got a root value of C8T1. Both will be abnormal if it is a focal neuropathy. But the radial innervated muscles, if you do EMG, that is C6 and C8, that is triceps, and the ulnar innervated abductor digiti minimis C8T1 are normal. That's all. You have to do EMG of all these muscles to pinpoint that focal neuropathy is responsible for the disease state. A pattern of radiculopathy, which we'll study again when I deal with cervical plexus and lumbosacral plexus, and we'll discuss again. 2 or more abnormal muscles innervated by the same nerve root but innervated with different peripheral nerves. Just concentrate. 2 or more abnormal muscles innervated the same nerve root but different peripheral nerves. They're one peripheral nerve with different roots in the focal neuropathy. Example for this condition, look at the tibialis anterior muscle, which is important for dorsiflexion. L45 deep fibular nerve supplies. L5S1 is tensor facial lata, which is a superior gluteal nerve, and would be both abnormal in L5 radiculopathy. The muscles without L5 innervation would be normal, like vastus lateralis and L23. Okay. So plexopathy, this requires a knowledge of brachial and lumbosacral plexi. If we look at the posterior cord lesion, the deltoid C5, C6, which is basically from the upper trunk, the posterior cord, axillary nerve, and the extensor indices C7, C8, middle and lower trunks, the posterior cord and radial nerve, both would be abnormal, right? Both would be abnormal. Other muscles supplied by the same cervical roots and trunks, but by the medial and lateral cords would be normal. So plexopathy is a bit difficult to pinpoint. Common patterns include abnormal muscles affecting the one cord, one trunk, and several isolated nerves from the plexus. So posterior cord, as you know, as it ends with the axillary, the radial nerve and axillary nerve, and axillary nerve supplies the deltoid, and the radial nerve supplies the triceps, also extends at distorum. So these are the important things which you can do EMG and establish. So the plexopathy, posterior cord, like C5, C6, C7, C8, T1, when the roots, trunks, divisions, cords are formed, you should know okay, what are the nerves that are coming. Like for example, the roots or C5, C6 will give rise to dorsal scapular nerve and the long thoracic nerve of Bell. The superior trunk will give rise to suprascapular nerve. That's the C5, C6 superior trunk. So like that, and the C8T1 will continue as the inferior trunk, also medial cord, and supplies the ulnar nerve. And part of the median nerve is very difficult, and we'll learn when we do the plexus, and that time tell you more about the complexities of the median nerve. The pattern in peripheral neuropathy and myopathy. In peripheral neuropathy, more than one abnormal muscle innervated by different peripheral nerves and roots distally, and the proximal muscles are spared, innervated by the same peripheral nerves and roots. Example is like a fibular nerve, common peroneal, deep common femoral nerve, innervates extends at distorum brevis in the foot is abnormal, but the tibialis anterior, which also has this nerve supply, which is normal. That's a peculiar peripheral neuropathy. The distal muscles are affected, but the proximal muscles are spared. Myopathy commonly affects proximal upper and lower limb muscles symmetrically. More distal muscles are typically normal in myopathies. So interpretation, let us revise once again. And the most important thing which you should know for all the students is that how the plexus is formed, what is the importance. You know that there is a dorsal root and there is a ventral root, and both is joined to form the spinal nerve, and spinal nerve divides into dorsal rami and the ventral rami. The dorsal rami go back and supply the paraspinal muscles, and the ventral rami join to form the brachial plexus or lumbosacral plexus. That's important, which you should know that how the plexus is formed. And it's very common to say that you will get confused if you're asked in an exam how the plexus is formed. Just remember that the ventral root and dorsal root, they join in the intervertebral foramina to form the spinal nerve. Subsequently, they divide into anterior primary rami and posterior primary rami. The dorsal or posterior primary rami go back to supply the paraspinal muscles. The anterior primary rami of C5, C6, C7, C8, T1 join to form the cervical plexus. So that's how the anatomy is there. And step one is, as I said, where is the lesion? Lesions have several characteristic patterns. In a peripheral nerve, example, the median nerve, look for more than one abnormal muscle innervated by the same peripheral nerve, but innervated by different roots. From radiculopathy, characters affects only one nerve root. Look for more than one abnormal muscle innervated by the same nerve root, but innervated by the different peripheral nerves, which I already told you last time. So second is, where is the lesion? Is the lesions from a flexopathy, that the posterior cord requires a knowledge of the brachial plexus and the lumbosacral plexus. The common pattern involvement of abnormal muscles affecting one cord, one trunk, or several isolated nerves from the plexus. So just look at, if you want to differentiate postganglionic, preganglionic, the nerve conduction studies, as I said, the snaps are very well preserved in radiculopathies. They are absent in plexopathy. There's one more point. Look for more than one abnormal muscle innervated with a different peripheral nerves and roots distally, but sparing the proximal muscles. You should think of a peripheral neuropathy. So, this how long the lesion has been present. As I said, decreased recruitment will be seen immediately following an axonal radiculopathy. Because Wallerian degeneration has not yet occurred, there will not be any fibrillations or positive shock phase. But 1 to 2 weeks down the lane, denervation of the paraspinal muscles, that is immediately following an axonal injury, the Wallerian degeneration begins to take place. When sufficient degeneration occurs, only then EMG needle picks up the changes. Because the paraspinal muscles are the most proximal muscles, they are the first to show signs of denervation. This can be usually seen 1 to 2 weeks after the active injury. Denervation of peripheral muscles in 3 to 6 weeks, then only sufficient Wallerian degeneration occurs. There to be therefore positive short waves and fibrillation potentials can be seen on EMG. We will see in the most distal muscles are affected later. Several months to a year down the lane, motor units long duration polyphasia, there has been sufficient time for the axonal sprouting to occur. One axon will now be innervating muscle fibers that were previously denervated. Because firing of these muscle fibers will be asynchronous compared to normal motor units. The morphology will resemble multiple motor units superimposed on one another and will have longer duration with increased phases. So now that is the interpretation of results. Now let us look at 4 of the common anomalies which will confuse us and which are the exam questions also, some of them. The common anomalies. Anomalous innervations are common and can lead to unexpected findings on neuroconduction studies. Recognition is very crucial to avoid erroneous interpretations. If an anomalous innervation is suspected, look for and rule out technical errors first. After technical errors, which I showed in the table here, then you think of anomalous. So, submaximal stimulation, stimulating off the side of the nerve, poor placement over the muscle belly, all will give rise to some NCS findings that are similar to those found with anomalous innervation. Unless you students start doing the neuroconduction studies, you will not be able to pick up. These common technical errors are increased proximal amplitude. If you observe, the possible error is distal site you are not stimulating well, that is submaximal. The supramaximal means you try and increase the strength of the stimulus you are giving and see that the amplitude becomes very large and stays there. After it stays there, you increase another 20% stimulus strength. That is the supramaximal stimulus strength. If your observation is decreased amplitude and or initial positive deflection of the CMAP waveform, what is it that may happen? Suboptimal stimulating electrode placement, and that placement electrode is not clear. You put it correctly. Stimulation is happening off the nerve site. The third observation, inconsistently decreased amplitude. The recording electrodes may come off the motor points. So suboptimal electrode placement over the muscle belly. There's a change in morphology and amplitude. There may be volume conduction and stimulus spread. The stimulating neighboring nerves or muscles when you apply too much of jelly and it is connecting one electrode with the other electrode. So once the technical errors are excluded, the common nerve conduction studies findings that could suggest anomalous innervation of muscles. They include lower CMAP amplitude at the distal site compared with the proximal stimulation side, which we usually think is due to conduction block. Second point is initial positive deflection of a CMAP. Positive deflection means it should come down. Normally it should go up like this. This is the amplitude that either seen, but here it is going down and then only it's coming up. So that is another one. Abnormally low CMAP amplitude with supramaximal stimulation, and you are increasing the stimulus strength, but the amplitude is dismally low. Abnormal waveform morphology for the nerve or muscle being studied. So there are 4 extremity anomalies are seen in the upper limb and 1 in the lower limb. The Martin Gruber is most common, and Marinacci and Richer Kenyu and all ulnar hand in the upper limb. The accessory fibular nerve in the lower limb. These are the things which will confuse us. You can see the comparison. Martin Gruber, you can see how the nerve. This is the median nerve, and median nerve joins the ulnar nerve here. And similarly, the ulnar nerve can join the median nerve. And there will be a continuous structure. This is all muscles supplied by ulnar nerve. And this is normal pattern, which you can see. That is the median nerve. This is the ulnar nerve. This is a normal pattern. Let us look at Martin Gruber anastomosis, which is an exam question. So you should remember this. Martin Gruber anastomosis is a common anomaly, which is a prevalence of about 25%. It is an autosomal dominant inheritance pattern. It's a C8T1 ulnar nervomotor fibers that run with the median nerve proximally until they finally cross back over to the ulnar nerve in the forearm. This is called median to ulnar crossover. 91% of cases supply the anterior interosseous nerve and 68% of cases are bilateral. By the way, anterior interosseous nerve supplies the flexor pollicis longus and flexor digitorum profundus 2 and 3, also pronatus quadratus. There are three muscles supplied by the anterior interosseous nerve. So there will be anomalies in the conduction of these. So now if you are conductor site of stimulation and pickup, you are stimulating from median nerve from the elbow and you are trying to record from abductor pollicis brevis, then the nerve fibers that will be contributing will be median plus the Martin. You can see that you can have both the fibers that are contributing to this. Median wrist, if you are supplying, that means you are supplying from here. You are stimulating from here, but you are recording here. So you got both the fibers that you are stimulating, and this is the CMAP you are getting here. But if you are stimulating at the median wrist, if you are stimulating only here, then you can do only median nerve. And median elbow and first dorsal interosseous, you can stimulate the first dorsal interosseous on the other side, dorsal side. Then also you have the Martin Gruber anastomosis fibers and ulnar elbow. So you can see ulnar here, and also this is ulnar stimulation, and you can see FDI. And then median wrist FDI, and you are sending median wrist, but the recording electrodes are first dorsal interosseous, and ulnar wrist, ulnar plus MGA. So there will be different waveforms which are going to show because of this anastomosis. The Martin Gruber anastomosis, as I said, is an exam question. So you can see the waveforms, you can see the initial positive deflections, the loss of amplitudes, the abnormal waveforms which you can see. So the waveform variation between median and ulnar nerve stimulation at elbow and wrist sites in the presence of a Martin Gruber anastomosis. The A and R B represent the pickup over the abductor pollicis brevis. A is demonstrating an increased proximal amplitude because it contains both the MGA and median fibers here. That's why you have a greater amplitude. And whereas B only contains median fiber, so the amplitude is less. The amplitude is less when compared to this. C to F represent a pickup or the FDI muscle, and the first dorsal interosseous is stimulated from the elbow as well as from the wrist and median and ulnar sides. C demonstrates stimulating the median nerve at the elbow and carrying only MGA fibers. D shows ulnar nerve stimulation at the elbow and contains only ulnar nerve fibers. E demonstrates stimulation median nerve at the wrist side, so there is no CMAP at all. F represents the stimulation of the ulnar nerve at the wrist, containing both ulnar and the fibers, so the amplitude is more. So these are some of the waveforms which are not the correct waveforms. It occurs as a combination of three types. Type 1 MGA fibers supply the hypothenor muscles in 41% to 61% of cases. Type 2 fibers and at FDI in 95% to 100% of cases. Fibers supply the adductor pollicis and deep head of the flexor pollicis brevis in 14% of cases. So the electrodiagnostic findings in Martin Gruber anastomosis often the initial finding in MGA will be a positive deflection, large amplitude of the CMAP, and you see or a large amount of CMAP when studying the median nerve at the elbow, with pickup at the abductor pollicis brevis. So it simulates a conduction block. MJ does not innervate the APB. However, it does innervate the adductor pollicis, deep head of the flexor pollicis brevis, which also are located at the thinner eminence, and alter the CMAP recording over the APB, larger amplitude or positive deflection. That's all. So the electrodiagnostic finding of decreased ulnar CMAP at the elbow stimulation compared with the wrist may mimic the conduction block, sometimes referred to as pseudo-conduction block. If there is an increased median CMAP at elbow compared with the wrist, they ensure that median wrist stimulation is supramaximal. I told you what is supramaximal. If there is an initial positive deflection on the median CMAP waveform, ensure the recording electrodes are on the motor point of abductor pollicis brevis. Recording site should be correct. Abnormally fast conduction velocity across forearm segment of the median nerve in patients with CTS. Confirm CTS with sensory and comparison studies, other CIS, which we'll again study later. So these are some of the important Martin Gruber anastomosis, was very interesting. And so the confirmatory studies stimulate median and ulnar wrist and elbow while recording electrodes over FDI. So first dorsal interosseous, you keep the electrodes and stimulate median and ulnar from the wrist and elbow whenever you suspect this. Okay, that's important point. Stimulate the median and ulnar wrist and elbow while recording electrodes are first dorsal interosseous. A CMAP response from median stimulation at the elbow wrist FDI pickup will be present if MGA is present. Ulnar wrist CMAP, that's amplitude, the ulnar and MGA fibers will be significantly higher than the ulnar pickup from the elbow CMAP amplitude, because their only ulnar fibers are present and may be perceived as a conduction block. However, a pseudo conduction block, because the ulnar elbow stimulation activates only ulnar fibers, the ulnar wrist stimulation activates ulnar and MGA fibers, so the larger amplitude. Medial stimulation at elbow with pickup or FDI contains only the MGA nerve fibers contribution. Second channel can be used while stimulating at the median elbow to observe the co-activation of the hypothenar or the other muscle groups. What is clinical significance? In patients with an ulnar neuropathy proximal to the MGA crossover, intrinsic hand weakness will be less severe. A median nerve lesion proximal to the crossover in the elbow could lead to some intrinsic hand weakness. So whenever you get a difficult, see, unless the technician doesn't know this, technician don't know about anomalies. Some people may be knowing, but you also should know what you are interpreting. So Marinesi anomaly is a similar communication to the MGA in the upper extremities, Marinesi anastomosis, which occurs when there is an ulnar to median crossover in the distal forearm. You can see that there's a crossover of the ulnar to median in the distal forearm. This is less common than MGA with a reported prevalence of 4%. The deep branch of the ulnar nerve in the hand crosses to recurrent median nerve in the hand. That is anterior interosseous nerve. This results in a dual innervation of the thinner muscles, that predominantly ulnar innervation of the thinner muscles. It is common and may occur in up to 80% of the hands due to the dual innervation of thinner musculature. It may not be immediately obvious on routine nerve conduction studies. However, there is a median elbow to APB abductor pollicis brevis, median wrist to abductor pollicis brevis, ulnar elbow to APB, ulnar wrist to APB. So here in the previous anomaly, we were putting the electrodes on first dorsal interosseous. Here we are putting the electrodes on abductor pollicis brevis, and we are seeing the various waveforms, as you can see this come. So I'm not going to go into the details of this Risch-Canio anomaly. This is a between median and ulnar nerve stimulation elbow on this side's presence of this is a waveform variation that Okay. Sorry. It's here. We're back. And the all ulnar hand is a rare finding in which all thinner and other intrinsic hand nerves are all innervated only by the ulnar nerve. This is an ulnar to median anastomosis. The nerve conduction studies, there may be little or no evoked motor response with stimulation of the median nerve, but a decent CMAP is seen with ulnar stimulation picking up over the abductor pollicis brevis. Rare anomaly, and it is important to avoid volume conduction with any wrist stimulation, right? So the upper limb, and the only one anomaly that is left, that is the lower limb, that is accessory fibular nerve. It is a AFN is a branch of the superficial fibular nerve that splits at the fibula head. It's a fibula head towards the lateral malleolus and innervates the extensor digitorum brevis. This results in a dual innervation of the EDB muscle from deep as well as the AFN, that is accessory fibular nerve. Then autosomal dominant inheritance pattern with a prevalence of 23% and is bilateral in 57% of cases. Perform basic fibular and tibial nerve conduction studies. If there is an increase in amplitude at the fibular head stimulation, stimulate the AFN at the lateral malleolus, recording over the extensor digitorum brevis. If AFN is present, there will be a response generated from the stimulation on the lateral malleolus. The deep fibular nerve ankle stimulation plus the AFN stimulation will be mildly higher than the stimulation at the fibular head. So unless you know how to stimulate EDB, it is very difficult to understand. The EDB muscle is stimulated by two places. One is just above the ankle joint in the midline or slightly to the lateral side, and then the one is in the fibula head. In addition, that what we're suggesting is if you stimulate the lateral malleolus also, there may be a CMAP generated from the EDB. Avoid overstimulation of the lateral malleolus to prevent volume conduction to other muscles. Deep fibular nerve lesions may appear incomplete due to dual innervation of EDB by axillary fibular nerve and deep fibular nerve, or what we call common peroneal nerve. So these are all the anomalies that can that can confuse us. So they are the waveforms which can happen. The muscle that is to be stimulated is EDB, fibula head, anterior ankle, and lateral malleolus. Then you can see the waveform that are coming. So these waveforms will tell us that there is an anomaly. That anomaly you have to identify. So I think with this, we're going to complete this class of introduction to nerve conduction studies. The next class onwards, we will be discussing disease states per se, and to some extent, mostly we'll be stressing on electrophysiology aspects of this. Any questions on this class? So I hope I am able to sensitize all of you about the electrophysiology, the importance of the electrophysiology, and you should try and read. And these lectures are available on the YouTube, so you can go back and pick up some points which are important for you. But you start doing the electrophysiology. That's most important. You should at least be able to stimulate 1 or 2 months. You practice on the machines and sit with the technicians and start practicing them. So, are we having any questions or any doubts from anybody? So any doubts or anything you want to ask about the class which we had? We dealt with most of the orthodromic, antidromic conductions and important diagnosing demyelinating neuropathies, and also okay. All right then. If there are no doubts, thank you very much. We'll end the meeting. Good night. Welcome.